Hey guys, Woodruff here. So the last upper gastrointestinal disorder is going to be peptic ulcer disease. So like I mentioned in my last video about gastritis, this is an extension of gastritis in that a lot of people that have gastritis end up with ulcers, or a lot of times people have peptic ulcer disease, but it all started with inflammation in their stomach. So this is very similar. Except the difference is that with peptic ulcer, that you can have the ulcers in your stomach or in your small intestines. Um, and there's actual ulceration of the tissue versus that just being inflamed and irritated, actual ulcers form. So there, and this is like a complete destruction of the stomach barrier, whereas with gastritis, it's irritated, it's inflamed, it might be partially broken down, but this is a complete destruction when you have that ulceration. So you're going to see a lot of the same risk factors. There is some genetic components here, but the same stuff: smoking, stress, diet, the H. pylori, NSAIDs, a lot of the same stuff can cause this. So, like I mentioned, there are stomach or gastric ulcers, and then there's duodenal, or which are intestinal ulcers. So gastric ulcers are less common, whereas duodenal ulcers are more common. Gastric are more prevalent in women and those that are older, like greater than 50. And I don't like to say greater than 50 is older, but I should say those that are older than 50. And I actually did this as there was a test, not a test the other day, but I was looking at the student who is we have these right on walls, and the student was writing out like something for a different disease process, and they're like happens more in older people, and they started to write 40s, and I was like, oh my god, like I'm sitting there, I was like, if you think 40s is older, my Lord Jesus. So yeah, I was kind of a little nervous there. And so like then he erased it and he changed it to 50, and I was like, it's getting a little better, because like he was getting pretty close to saying that I'm getting old. So, it was a little bit fine territory. But yes, I shouldn't say that 50 is older, because it's not really. By the way, this like brown thing is just a Taco Bell dog butt. So don't worry if it's kind of coming in and out. It's nothing obscene. It's just a butt of a stuffed animal. Anyway, gastric ulcers are have a high risk of mortality or death, and usually they're caused by the H. pylori, NSAIDs, and reflux. Duodenal ulcers, on the other hand, happen more between the ages of 35 to 45. That again usually caused by H. pylori, and then it's also there's a connection between those that have COPD, liver and kidney disease, and getting duodenal ulcers as well, which is interesting. So, what are we going to expect to find for peptic ulcer disease? We're going to expect that they're going to have some general symptoms like pain, bloating, nausea, vomiting. With gastric ulcers, we're going to have the pain a little higher up in the epigastric area. Where with duodenal ulcers, their pain is can sometimes even cause back pain. It might be a little bit lower. Gastric ulcers usually happen a couple hours after meals, like 1 or 2 hours, and the pain is described usually as a burning or a gas. Oh, I can't even say that word. Gas-like. I'm gonna just say gas-like because I think it makes me sound less stupid. Burning or gas-like pain. And food makes it worse. I'm going to talk about why in a minute here. Whereas duodenal ulcers, usually it's hours later after a meal, like 2 to 5 hours. And like I said, it's more cramp-like pain and can cause back pain. So then there's like a little mnemonic there. But here's the thing. So this might not make sense. But once I explain kind of how this works in the body. So this is what you want to think about is that someone has a gastric ulcer. It's in their stomach. If you start eating, like, you go and you eat a meal, excuse me, what happens when you start eating a meal is that your body's like, hey, I have food here, I need to break it down. So what does it do? It secretes more acid. So I have an ulcer in my stomach, I eat food, more acid is produced, that's going to irritate that ulcer. So these people are going to complain, man, I feel worse after after I eat food. Where on the other hand, duodenal ulcers, there's not that um there's not the secretion of the acidic, we call it stomach acid that's secreted in the duodenum. There's not that secretion, and so when food comes in on a duodenal ulcer, it actually kind of pads or protects or kind of covers the ulcer, so there can actually be less pain. So sometimes they feel worse when there's nothing touching them, but when the food comes in, it kind of coats or covers the ulcer, so their pain can actually be less. So gastric ulcers are worse when you're eating because of the acid production. Duodenal ulcers are better when you have an so gastric is worse when you're eating. Duodenal are worse when you're not eating, and they're better after what do you call it? You've been like you just ate, because the food covers up the ulcer and it makes it less painful. All right. So, my priority assessments for this patient are usually going to be assessing for pain. We want to ask about when their pain is at its worst. Where is it located? Is there any other symptoms, nausea, vomiting? And especially, we want to focus on, of course, if there's any blood or anything else. So I guess I need to add here assessing their emesis if they have any, and looking for blood. Um, and then of course looking for what might be causing it, because everything here comes down to we need to get to the bottom of the cause. Is it an infection? Is it a lifestyle thing? What is it? The most accurate way to diagnose these are going to be through endoscopy, and this is how it would kind of look in the endoscopy. You can see these ulceration, how deep these go. Look pretty painful. And so we can also take samples and test if they have H. pylori, which can give us more information. Because again, if I'm thinking, oh, hey, they just have an ulcer because they're stressed out, but then they have H. pylori, it's going to take a lot longer for them to get better if we don't treat the problem. We can also do barium contrast to see. And the barium contrast, I don't think I've explained this very well. It's where you drink like dye, and it helps to see how stuff is traveling in the stomach, and a lot of times can tell with flow things, or if things are if there's issues in the structures and the tissues, it can help to highlight or bring those to light. Check CBC. Why would we want a CBC? Well, we talked about with gastritis, it's possible for them to bleed, but with peptic ulcers, there's, I think it's like bleeding is one of the most common side effects. So we're going to be checking the H&H. So I'm definitely looking at that hemoglobin, seeing if they have any sort of breakdown of their, or sorry, decrease in their hemoglobin to see if they're bleeding. Because these patients that are bleeding, like some of them may be bleeding and they're vomiting blood, but others of them can be bleeding and digesting it, especially if it's a duodenal ulcer. So it's also why at the bottom here I have check for occult stool. And occult means hidden. And so it's looking for hidden blood in the stool. In other words, like sometimes people poop and it's like they have black tarry stool, and you should think, ooh, black tarry stool, bleeding. Like that should be your first thoughts. I know we learned about iron, and it can turn your stools black, and it's okay. But really, like, when you're on a nursing school exam, you should think for what's going to be most common. And if someone has black tarry stool, it's more likely that they're bleeding than that they're on an iron supplement. So when it comes down to it, we're going to check, and we want to do the occult stool, because like I said, some people are going to have obvious signs of bleeding in their stool, but other people, they just have little bits of it so that it can't be seen well. So that's why we want to break down and look in that stool and really see if there's any remnants of blood or digested blood. Then we're also going to look at how the liver and pancreas are doing. Just check for those, because they can, we call it be affected, or there can be issues and stuff like that related to the liver and the pancreas. Or sometimes, like, again, they're like, what do you call it? When we start getting into, especially when we get into the intestines, all these, as we go into biliary disorders, it'll make more sense. But all of these are parts of what we need for digestion and processing of things. So yeah. Anyway, peptic ulcer disease is better if there's less pain or symptoms, good nutrition, no complications. But of course, the opposite would be that they're worse. And the big complications we're going to be looking at for these patients are bleeding, fluid and electrolyte imbalances if they are vomiting. So think the dysrhythmias. There is an even higher chance of an acute abdomen or a perforation of the abdomen with these deep ulcers. And then also what's called a gastric outlet obstruction. And effectively what this is that your gastric outlet is pretty much where your stomach dumps food from your stomach into your duodenum. And this area can become very inflamed, narrow, think like stenosis, and it leads it where it's hard to dump food from your stomach into your intestines. So yeah, so that's another possible complication. So like I mentioned, bleeding is the most common complication of peptic ulcer disease. And you always want to think about, again, how are we going to know someone's bleeding inside? Because a lot of times, some people, it might be very obvious that they're bleeding. They might be vomiting blood, black tarry stool, something like that. But other people, it's going to be more subtle, or we're not going to be able to see it right away. So you want to think about, like, most times students will tell me, oh, their abdomen's going to get really bloated. And that's possible, but earlier on, usually if someone's bleeding inside, the things that we're going to look for are going to be a decrease in blood pressure, increase in heart rate, and changes to mental status can also be an earlier sign. When people are losing blood, they can start to have a big change there. Perforation is the most deadly complication of peptic ulcer disease. And with with perforation, this is, again, those 3 P's that we talked about, where we're worried about pain, and the pain is a sign that there is perforation, and then that perforation can lead to peritonitis, which is, again, that inflammation of the peritoneal cavity that can lead to like sepsis and really bad systemic infection. So for perforation, I'm going to look for sudden severe pain, a rigid abdomen, and absent bowel sounds. And if there's a sign of perforation, I want them to be nothing by mouth, because they're probably going to have to do an intervention. We'll talk more about that with lower GI. Ooh, here's a fun question. So for the following prescriptions, indicate whether it's contraindicated, indicated, or unnecessary for a client with peptic ulcer disease. So this is a great way to study. So you're going to see a lot of these questions as you move throughout nursing school and as you're doing your NCLEX prep and your actual NCLEX. So it's great while you're studying to actually sit there and write out, okay, what is indicated for each patient, what's contraindicated. You don't necessarily have to go into unnecessary, but a lot of times if you sort those out, it can definitely help. So when you're on an exam, like I always tell students, know what you want to do for a disease process, and also know if there's stuff you absolutely don't want to do. In some disease processes, there's not a long list for contraindicated, but it's always good to know in other words, don't just study the right answers, study the wrong answers too. Like, what would be a bad answer? And that way, when you get to an exam, not as much can shock you. Because if you just study what's right, then sometimes some of those distractors can really throw you off. So it's really good to know what's okay and what's not okay. All right, so sulcrafate PRN for indigestion. So that's someone that is getting sulcrafate. If you guys remember, sulcrafate is that protectant. It coats the bowels, in order to prevent them from having so much irritation. On their, so much irritation on their stomach with the additional acid that they have going on. And so we have to think, like, when you're answering a question like this, you want to answer like, okay, if I give this, is it going to help the patient? Is it going to hurt them? Or is it going to do nothing? And the nothing is the unnecessary, hurting them is the contraindicated, and help them is going to be indicated. So sulcrafate is going to coat the stomach, which will help to protect it. And remember, what is the problem here with peptic ulcer is that they don't have the protection that they need for their stomach. So sulcrafate is good and can help, so it is indicated. Excuse me. NG tube. So NG tube, we've talked about, it's used for decompression or helping to remove excess acid, or if you're having trouble with emptying, it can be helpful. It can really help if someone has nausea as a symptom and help to relieve a lot of their discomfort. I don't know if every patient with peptic ulcer is going to need it, but I have to just keep this really simple. And so don't answer this like, is every single patient going to need it? It's just saying, if you saw this order, would you say, ding, 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 no, doctor, that's going to hurt my patient? Or would you say, I don't need that, that's not going to help at all? Or is there a possibility this could help your patient? An NG tube, maybe not for every patient, but for a lot of patients with peptic ulcer can be helpful. So NG tube is indicated for some patients with peptic ulcer. Oxygen protocol to maintain SpO2 greater than 95. So you may sit there and say, well, this is a really general order, and I think every patient this would be indicated for. But we have to think, is it going to actually help? So we need to go back and say, is there a oxygen problem or issue where people with peptic ulcer would need extra oxygen? And so for this one, I don't think it would hurt them to have oxygen, but I don't think this is going to be top of the doc's list to give them. It might help with other issues, but it's not necessarily going to help their peptic ulcer. So to me, this is, I'm going to say in the middle, unnecessary. Regular diet. So, what do you call it? I would think a patient that is having peptic ulcer, there's times, especially with the inflammation, that we might need to actually be on a special diet, or we might even need to be NPO for a while that ulcer heals. So I'm going to say that a regular diet is probably actually going to be contraindicated because it could cause some harm. They may need to have some restrictions in order to stop them from having such increased pain and problems. Like, in other words, like if my problem is I have this ulcer and then I keep eating, which keeps releasing stomach acid and breaking down this ulcer over and over and over again, kind of like ripping a scab off over and over again, I might need a different diet because a regular diet could include foods that are irritating to the stomach, or the intestines. So I'm going to say contraindicated and hope that I'm right and that I'm not crazy. That's half my day is just like, are you crazy today? Or, and there's a patient that asked the other day when I was at clinical, they were like, is this real? Like, is this hospital and me being in this hospital real? And I'm like, man, I ask myself that question every single day. And sadly, it's real, at least as reality as I know it. So pantoprazole IV push. So for this medication, if you remember, prazole decreases the acid toll. It is a proton pump inhibitor. It starts with the P, and has the P in prazole. And so this is my, you can remember P and panto, P and prazole, PP. There's no I, but maybe the PPI for IV push. All right, just kidding. But yeah, so if this helps you to remember PPI, I hope it does. But just know that you can give pantoprazole oral too. So that would be PPO. So I don't think that's necessarily the best way to remember it. But if you remember there's two P's in it, then maybe that'll help you. Anyway, so this is something that's going to help maintenance overall to help to decrease the amount of acid you have. Now, we said one of the issues here is you have this acid that keeps irritating these ulcers. So I don't think it would harm the patient, and I think it actually could help the patient. So it's indicated. Ibuprofen PRN for pain. So what do we remember about ibuprofen? It is a stomach irritant. So because ibuprofen is a stomach irritant, I don't think it's going to help the patient. It's not that it's unnecessary. I actually think it can hurt the patient. So I'm going to say contraindicated. Last but not least, antibiotics. So you may be saying, well, we don't know what kind of peptic ulcer disease they have or what their cause is. But here's all it's asking is simply, if you saw this order, would you sit there and be like, oh, that's going to hurt my patient, or oh, that's not necessary? Would you say, hey, this could help? Is it possible? And antibiotics, yes, they can definitely, they're specific targeted. Certain antibiotics can treat peptic ulcer disease when it's caused by H. pylori. So sulfurate, NG2, pantoprazole antibiotics are indicated. The oxygen is unnecessary. The regular diet and ibuprofen are contraindicated. All right, so let's try. Okay. So the medications, like I mentioned, we're going to do like a lot of the acid meds. So all the meds that we talked about that help to decrease acid. And remember, we take our PPI-H2 receptor blockers daily. The protectants we take before meals to coat the stomach. And then antacids are going to be used after meals for decreasing acid. We want to avoid irritants. So we want to be careful with these patients when it comes to the foods and other things that we're giving them. We want to avoid the medications that are irritants. We want to avoid what we call foods that are going to be irritating to foods and drinks. They may need IV hydration and or NG tube, and surgically the things that we can do. Sometimes the ulcers get bad enough where we actually have to remove part of the stomach. Other times we have to do a vagotomy, which is where they take the vagus nerve that stimulates you to release gastric acid, and they sever that so that you're not producing as much gastric acid. They don't completely shut it off, but they cut some of the pathways to that, so you make less stomach acid. And then also what's called a pyloroplasty, and the pyloroplasty is specific for people that have that gastric outlet obstruction, where they're like here, if you look here in the stomach, at the bottom of the stomach is where things get into the duodenum. And there's supposed to be a sphincter there that's supposed to open. Sometimes it gets very narrow. And so a pyloroplasty is to open that up to allow for passage of food from the stomach into the intestines. And then just know with all gastric surgeries, we're always going to watch out for dumping syndrome. If the cause is from H. pylori, we're going to treat that. And H. pylori actually requires multiple antibiotics because there's such bad drug resistance. And so remember some of the general stuff with all antibiotics. We want to know kidney function, allergies. We also want to watch for C. diff. So in other words, this patient might, their gastric or duodenal ulcer could get better, but they could end up with an opportunistic infection or, a resistant infection with C. diff. So you always want, anytime someone's on antibiotic, you kind of want to watch their stool patterns. The most common side effects with these are always going to be GI. So if they're oral, then we definitely want to give them food with them and give the food with the doses and be cautious because they can definitely affect the patient's how they're feeling. So the triple or quadruple therapy is what's used. There's multiple of them. It just depends on the patient's allergies and things like that. So usually the triple therapy will involve some sort of PPI. And so the triple or quadruple therapy isn't necessarily all antibiotics. It includes a proton pump inhibitor, and then they combine stuff like amoxicillin, clarithromycin, metrodon. I was trying to say it real quick to think it would come out better. I'm gonna call it Flagyl because that's what I know it as. Metronidazole. Oh, maybe I said it real good. Ish, maybe not. I don't know. I'm not going to get confident because then I end up making a butt of myself. Or tetracycline. So those are some of our options. And so you don't have to know all the different combinations, at least for the exams we do, but just know the options here. So as the nurse, what are we doing? We're going to monitor for complications like bleeding, perforation of that gastric outlet obstruction. Also keep in mind, like I said, the other complications that can happen after the surgery, like dumping syndrome. If you don't remember dumping syndrome, go back and watch my video in nutrition or watch, there's some great videos online that you can like kind of see out what it looks like. I think that helps. Reducing all the irritants. So stopping smoking, reducing or stopping alcohol use, diet changes with avoiding that spicy, fatty, acidic. Rest and decrease stress. Stomach ulcers and stomach or intestinal ulcers both are highly associated with stress. So especially nursing school, I've known many nursing students who get ulcers, and I'm so sorry for you. I sometimes feel like from teaching that I have ulcers too, but so far, at least none officially diagnosed, but I get it. The stress is overwhelming. We talked about pain. We talked about pain and symptom control and that, we want to give medications to help with pain, but also we don't want to cause any irritation of the stomach as well. And then doing really good oral care if they're vomiting. This patient can have no aspirin or NSAIDs for 4 to 6 weeks, avoid other irritants. Remember to teach them to finish all antibiotics, and if they have any worsening of symptoms, they should report them. All right, that's it for upper GI. There is literally crap coming next. So all the diarrhea, constipation, and other fun stuff. So looking forward to seeing you there. Have a good night.